Hello.
Hi, how are you doing? It's Nicola here.
Hi, Nicole.
Do you want to test your slides, the intro slides? Are you comfortable?
My slides.
The introductory slides.
Um, uh, I don't know if I do. I was supposed to have introductory slides.
Yes, but I can share them from my side as well. I sent them in an email on Friday.
Oh, I see. I've got them.
Cool.
All right, I see. That's perfect.
Hi, Prof. Busk.
Hi, hello everybody.
Hi there.
Hi, Perry. So I will share my slides then. I will then just prepare.
Would you like to test them so long?
So this is the best use of a medical textbook now these days is to put the laptop on it to lift the camera.
Yeah, that's true. The world is changing.
So the slides you can see now.
I can see your slides, Perry, and I guess you will do the intro and then I would share my slides, correct?
Yes, that's the plan.
Mm-hmm.
Um,
Okay, I want to play the introductory video in the meantime then.
Okay, good afternoon, everyone. It's 4 o'clock. I'm Perry Lubbenberg. I'm a hematologist in Cape Town, and it's a great privilege to chair this session of the Hematology Deep Dive. We have a very distinguished speaker who many of us are very, very familiar with and have met in person. He was here in Cape Town at last year's Heme Onc meeting and visited some of the practices around the country. And I speak of Professor Christian Busk, who is from Ulm Hospital in Germany. And he's a distinguished professor who is in several leadership positions in hematological malignancies, including the president of the German Lymphoma Alliance, as well as a founder of the European Consortium for Waldenströms. He studied medicine at the University of Münster and earned his doctorate in 1993 in hemato-oncology, and has worked in Göttingen, Vancouver, and Munich, and has several academic awards and fellowships, including from the German Research Council and the International Society for Experimental Hematology. His research centers on hematological malignancies, particularly Waldenström's macroglobulinemia, marginal zone lymphoma, and follicular lymphoma, and AML as well. So before I hand over to him, I'm just going to he'll be discussing the use of BTK inhibitors in the treatment of B-cell malignancies. And his talk will cover a variety of indolent non-Hodgkin's lymphomas and the role of the various BTK inhibitors therein, as well as other potential treatment options for B-cell malignancies. It's with great thanks to Beijing, who sponsored this session. And this is in partnership with Blood SA and the South African Clinical Hematology Society and SASETS. Many thanks to Nicole, who does a lot of the work arranging this, and Prof. Stelfer Berg and Gerdien Kritzinger, who are part of the Blood SA team. All of the sessions are going to be recorded and can be found online at bloodsa.org.za. You are welcome and encouraged to interact with us during the session, and please make comments as we go in the chat box, which I can read out during the Q&A. And also, yeah, so we look forward to some robust discussion after Prof's presentation. This meeting is CPD accredited, and you would have all registered for CPD points when you signed up for the deep dive registration. You need to stay on for at least 1 hour to be eligible for the CPD points. There's a mailing list which you can join on the website, and look forward to any feedback. And there will be a survey at the end of the meeting that you can complete anonymously. Also, an announcement of our annual conference, which is going to be on the 19th to the 21st of September. Registration is now open, and it will be held at the Centricity Conference Center in Cape Town. The program looks really excellent and exciting, and it's going to be a great meeting. So I look forward to seeing you all there. And there'll also be a specific HHT conference on the 19th at the same location, which I'd also like to advertise. I think this is a really good initiative that Blood SA is driving to increase the awareness and expertise in HHT treatment in South Africa. So please take a look out for that. So the agenda, as I've discussed, is to talk about BTK inhibition for the treatment of B-cell malignancies. And then we'll have a question and answer session at the end. I will see you then. And next week, we'll be having a discussion on antiphospholipid syndrome. So that's on the program. But for now, let me hand over to Professor Busk. Please take it away.
Yeah, thanks so much, Barry, for the very kind introduction. And I think it's really a privilege to be part of your Dive Deep initiative. So I heard wonderful things about it, and I already know, as Barry said, from my last visit, that you are such an active community. So this is really, really great, and I'm sure that this 1 hour we have will fly, and it's really strict. You have to stay for 1 hour to get your credit points. You are even more strict than the Germans. So I will try now to share my slides. Let's see. And I hope you see it. Perry, everything fine?
Yes, we can see that very clearly. Thank you.
Okay, perfect. Yeah, so then, let's start. So the topic is the role of BTK inhibitors in B-cell malignancies. And as you see, of course, it's a very broad topic. Why? Because BTK inhibitors getting so important in many, many different B-cell malignancies. But you will see that I will focus on chronic lymphocytic leukemia and on Waldenström's macroglobulinemia. But we could also talk about marginal zone lymphoma, mantle cell lymphoma, follicular lymphoma. So, and of course, I invite you when you want to discuss anything in these lymphoma subtypes, please put this into our discussion part at the end. So as said, I will structure my talk a little bit into general thoughts, and then I will move to CLL and Waldenström. So let's move forward. Let's see. Yeah, it works. So these are my disclosures. And as I said, so I would like to start with some general thoughts, because I also heard that some of you would be also interested into more practical points, how to work with the BTK inhibitors, and to learn a little bit about the second generation BTK inhibitors and their differences and so on. So I think the first thought is, why should we do at all do a talk about BTK inhibitors? Why should we waste 1 hour of our lifetime on BTK inhibitors? And I think because they are very popular, as you will see. And then the next question you could ask is, why do we need them? Why are they so popular, in particular in indolent lymphomas? This is here summarized. Why do we need them actually in indolent B non-Hodgkin lymphoma? So I think the word indolent B non-Hodgkin lymphoma is in some way misleading, because we know that indolent B non-Hodgkin lymphomas, when we face them in a relapsed refractory setting, they are not indolent. We learned this from CAR T-cell studies, from the bispecific studies, for instance, in follicular lymphoma, that when you have these indolent lymphoma in later relapses, they pose a major problem. I think it's the same for CLL, for Waldenström, which we will focus on today. So there's an unmet medical needs in the relapse setting in indolent lymphoma, despite the word indolent. When you look at the term indolent B non-Hodgkin lymphomas, we also summarize mantle cell lymphoma traditionally into this category. And when you look at mantle cell lymphoma, where BTK inhibitors play a major role, it's really not an indolent B non-Hodgkin lymphoma, with the exception of perhaps a smaller portion of patients, but it's really behaving like an aggressive lymphoma. So we need them in indolent B non-Hodgkin lymphoma. So there's an unmet medical need. Because sometimes I hear in talks, why are talking about this? They are so indolent, these diseases. But I think that's not true. And we need them because of toxicity aspects. You know that indolent B non-Hodgkin lymphomas cannot be cured. Whether you look at, at least when we talk of eradicating the disease, biological cure. And when we cannot cure a disease, you only would accept compounds which are not compromising the quality of life. And this is, of course, heavily depending on the feasibility of these drugs, of the toxicity side effect profile. So only well-tolerated drugs, I think we would accept in a setting where we do not cure. It might be different in aggressive lymphoma and so on, but at least not in indolent B non-Hodgkin lymphomas. And I think this is the second reason why BTK inhibition as a treatment principle is so popular in this field. So as I said, relapsed refractory patients, they behave really not like an indolent B-cell lymphoma, and we could, go for marginal zone lymphoma, but we could go for Waldenström's disease and so on. I just show you a follicular lymphoma, the classical, let's say, a model of an indolent B-cell lymphoma. So these are retrospective data. They are not including more newer treatment concepts such as, T-cell engaging treatments and so on. But I think it's still true when you look at the overall survival, and even more when you look at the progression-free survival, you see that starting actually from first relapse, PFS and also to some part overall survival is really imploding with a much inferior outcome for these patients, much shorter PFS when you look at these real-world retrospective data when you go into the relapsed refractory setting. Again, underlining that there is an unmet medical need and that we need new treatment concepts. And many of you are aware of the so-called POD24 phenomenon, which means that a considerable proportion of patients here for follicular lymphoma, around 20%, but it's the same proportion in marginal zone lymphoma, show a very inferior outcome when they actually show early progression defined as a progression within 24 months, within 2 years after initiation of first treatment. So this was the original publication defining POD as 2 years after diagnosis, but I think what we are using is the definition of 2 years after starting initial treatment. So I think this makes very clear the situation we have and the need for novel treatment concepts and the concept of avoiding chemotherapy to moving towards targeted treatment. And this is what we have with BTK inhibitors. It has been developed, and we have seen a tremendous progress in the management of B-cell lymphomas, and this will be also the topic today. So it's a story of success. So it's really fun, let's say, to give these lectures, to give these talks. It's a story of success. It's really a firework. We could also discuss today aggressive lymphoma. It's a story of success everywhere where you are looking at. And we have always to keep in mind where we started. So this is 80 years ago. This is, it's very interesting when you look at the right side, a very interesting publication, which is still accessible. So you can Google it. It's scanned in, and it's, if you want, so like a phase 2 study of lymphosarcoma called at that time. And of course, data protection was not that as today when you look at the photos. But yeah, chemotherapy was the starting point. Of course, also radiation and surgery. But the dream we had and we still have is to have the magic bullet in the treatment of cancer. And chemotherapy was not considered to be like a magic bullet, but in a very unspecific way, the left side bulldozer treatment and the dream away from classical chemotherapy. Also, another dream is to go to move away from IV treatment to, in the best case, oral treatment. And when we look at all these developments, which we now will discuss, exemplified by the BTK inhibitors, we have really made a lot of progress. And this is shown on this slide. You could show this for other B-cell lymphomas, but here for CLL. So where we started in the 40s, 1949 with chlorothamine hydrochloride and prednisone, chlorambucil. Actually, chlorambucil, we gave it still for a long time, and probably in some of the countries presented now here at our Dive Deep initiative, probably it's still given. And then, the rapid development, when you go to the present, to the bluish colored part of this slide, the rapid development of targeted treatment, rituximab as being the first one in the late 90s, but now, you can, it's amazing. Every meeting we have, there are so many new targeted treatment concepts. And here with the development of the BTK inhibitors, topic today, ibrutinib, acalabrutinib, and zanubrutinib. Of course, these are approvals in the Western countries, probably not the same you have in South Africa and in African countries. So the end of chemotherapy, I like this editorial citing Bob Dylan, the musician, by Bruce Chasen, and it was published 11 years ago. And CLL is actually the first disease where we can say that this question mark can be actually cancelled. We can discuss this, but when you have access to targeted treatments, there's no role of chemotherapy anymore, at least in CLL. So again, we still continue a little bit with general thoughts. Toxicity, as said, what you need are well-tolerated drugs if you do not cure in indolent B-cell lymphomas. And when you look at this, at the principle which we have in managing patients with indolent B-cell lymphoma, I think there's a key wording of Jan Waldenström: do not harm patients. And I think we always have to find the balance between efficacy in indolent lymphomas and toxicities. And again, to discuss with this the BTK inhibitors, this class of drugs is, I think, a very good compromise between this and a very helpful tool to find this balance you see on this slide. Example, CLL. Again, we will focus on CLL. And I just now want to show you a little bit where we are standing with covalent BTK inhibitors, the differences and challenges we have, or let's say the challenges we have with them and the differences between first and second generation BTKIs, and with regard to toxicity, how we can perhaps, very practically speaking in daily clinical life, use these covalent BTK inhibitors to, to follow the dream of a specific treatment, non-toxic treatment, what I showed you before. So when we look at covalent BTK inhibitors, there is an issue of specificity. I talked of targeted treatments, but you see, targeted treatment is always, relative. And so some of you will know these kinase trees, which show the inhibition of BTK in blue and the inhibition of off-target kinases. So if you want, so the red dots are standing for the unspecificity of these BTK inhibitors. And as illustrated here, ibrutinib is the first class, first compound in this class, has still, it's wonderful. It's a quite specific drug, but has still off-target kinase efficacy, which is much more reduced when you look at acalabrutinib or zanubrutinib. And when we think about, this about toxicity, it has clinical implications. And this is shown on this slide because when you look at the table and when you look at the off targets of ibrutinib, like all these different kinases, they can lead to potential adverse events, as shown here in this table, or on the right side in this cartoon. It can, lead to atrial fibrillation, bleeding, infections, and arthralgia. And again, always think about the balance between efficacy and toxicity. And we have also learned that when these BTK inhibitors are too toxic, of course, they compromise also efficacy, as we will see later on in head-to-head comparisons between these second-generation BTKIs and the first-generation BTKI ibrutinib. So when we stay always here now in CLL as a model disease, if you like, so we see that in a data set of nearly 12,000 Medicare beneficiaries with CLL, that nearly 50% of the patients discontinued ibrutinib within the first year. And when you now look in dark blue, let's see whether I get the pointer here, in dark blue, these are the ones which discontinued in 1 year or earlier. This portion of patients is highly enriched for adverse events, already saying that, that adverse events, or pointing to the fact that adverse events are the major reason why patients actually discontinue ibrutinib. And remember, ibrutinib should be our magic bullet, and you see that in real life you have already limitations of this magic bullet based on side effects. So this is also the same topic. Again, just another data set. So this is a multi-center retrospective analysis of patients with CLL treated in clinics and clinical trials, over 600 patients. You see the median progression-free survival. And when you look at the right at the table, again, discontinuation around 40% after a median follow-up of, let's say, 1.5 years. So a considerable proportion of patients discontinues treatment, and you see the reasons here: arthralgias, atrial fibrillation, rash frontline, and in the relapse setting again, atrial fibrillation, infections, pneumonitis, summing up to this quite high proportion of discontinuation. So now we have the problem of toxicity. So we face toxicities despite, let's say, the targeted nature of ibrutinib. So what can we do in daily life? So can we avoid toxicities? No, but we can reduce them by using next generation BTKI. So, and we have in CLL at least acalabrutinib and zanubrutinib approved. And here, as an example, zanubrutinib is a highly selective covalent BTK inhibitor. And we discussed the off-target effect, BTK, EGF receptor, ITK. And now you see here the IC50 values for ibrutinib versus zanubrutinib. So, and when you look at the IC50 values, you see that you need much more zanubrutinib compared to ibrutinib, for instance, to inhibit 50% of the activity of EGFR. So it's a ratio of 6:0. So when you now look, for instance, at JAK3 51 ratio, or at HER2 or TEC, HER2 is very dramatic. It's a 70-fold ratio, meaning you need 70-fold more zanubrutinib to achieve the same inhibition as ibrutinib, thus demonstrating you have a much higher selectivity. And don't forget that these off-target kinases are associated with toxicity, diarrhea, infection, cardiotoxicities. So these are, let's say, if you want, so in vitro lab data. So what about clinical data? And I think the most valid clinical data set we have from a prospective clinical trial is the Alpine trial in relapsed refractory CLL, head-to-head comparison, zanu versus ibrutinib, a large study. And when you look at treatment discontinuation, you have a major advantage for zanubrutinib versus ibrutinib. And of course, this means that you are here at risk also to lose efficacy. And this is what we actually see in this Alpine study with a significant improvement of PFS in the zanubrutinib arm compared to the ibrutinib arm. We are staying in this Alpine head-to-head comparison between ibrutinib and zanubrutinib. I don't have time to go through, but when you look at COVID-related hypertension, atrial fibrillation, neutropenia, just to focus here on atrial fibrillation, because the others, there's not such a major difference, at least in these percentages. But when you look at atrial fibrillation, any grade, there is a major difference. And remember, in the previous slide, atrial fibrillation is among the top reasons why to discontinue ibrutinib in the real-world data setting. And this is just shown here, atrial fibrillation with the cumulative incidence. There is more toxicity with ibrutinib, which then, of course, again, one driver of early discontinuation of treatment, which then affects, again, also efficacy. So no difference in hypertension, at least here in this trial. In the Waldenström setting, we see differences favoring zanubrutinib, but here in CLL, atrial fibrillation as the major driver of differences in toxicity. Again, another slide here, atrial fibrillation. We stay here now in the CLL field, but now with the second generation BTK inhibitor, acalabrutinib. And again, here the same phenomenon. When you look at any grade, there's less atrial fibrillation cardiotoxicity for acalabrutinib. When you look here for hypertension, also a benefit in hypertension. And I think this is very important in indolent B-cell lymphomas. So can we avoid toxicities? Yeah, as I said, we cannot avoid, but we can reduce them by using next generation covalent BTKIs. And here, I think a very interesting forest plot now comparing two second generation BTKIs. So I think we have the luxury to have two very nice second generation BTKIs, zanubrutinib, acalabrutinib. They have a different toxicity profile. Zanubrutinib had lower rates of AFib, flutter, infections in this data analysis, lower rates of adverse events, limit activities of daily living, GI toxicities, but acala, for instance, had lower rates of hypertension, neutropenia compared to zanubrutinib. So both are great drugs, and when you think about which second generation BTKI to use, you can remember this slide. So there is a, let's say, an individual toxicity profile between the two second generation BTKIs, and you can use the one which fits best to your patient. So how can we manage side effects if we cannot avoid them? Because also second generation BTKIs, of course, can have toxicities, and there are very nice guidelines how to do dose modifications for BTKIs. I don't want to go through because we have not so much time. I have the watch here, ibrutinib, acalabrutinib, zanubrutinib, first occurrence, second occurrence, and you can really try to avoid toxicity by not giving up this treatment principle. I think that's important. When you have good efficacy, but side effects, don't give up, but try to lower the dose to stay inside the treatment concept of BTK inhibition. Of course, it might be that in your patient, it does not work even despite lowering the dosing. Then remember this slide, you can switch treatment. And there are two very nice data sets here on acalabrutinib. So you have patients heavily treated with, heavily pretreated patients. So they stopped ibrutinib because of adverse events. And now you are treating these patients, heavily pretreated, having experienced ibrutinib-related adverse events. You are treating them with acalabrutinib. And you see it works that in the majority of patients, side effects which led to the discontinuation of ibrutinib did not recur. I think I have to move a little bit faster to go through to all these wonderful slides. So in the same concept here, again, you have CLL patients, ibrutinib intolerant, cohort 1, or even acalabrutinib intolerant, cohort 2, and now you are treating them with zanubrutinib. So you switch to zanubrutinib, and just to highlight here, ibrutinib intolerant, 84% do not experience the side effects which are listed here, which they experienced before with ibrutinib, and even the switching from a second-generation BTKI Acala to zanubrutinib works. And you see here again, 73% did not recur with zanubrutinib. None recurred at higher grade, 40% at lower grade. So think about switching from ibrutinib to second generation or even between second generation BTKIs. So now clinical data. First CLL. Let's stay in CLL, focus again covalent BTKIs. And you are aware that we have many highly published large randomized phase 3 trials which clearly demonstrated that targeted treatment with covalent BTK inhibition is superior to FCR, to BR, to chlorambucil obinutuzumab, and so on. Yeah, here are the trial names: ECOG, FLAIR, Alliance, Illuminate, Elevate, and Sequoia, and we will go to Sequoia in more detail later on. I think it's a very clear picture with a PFS benefit and even in some with the overall survival benefit. This is again shown here a little bit more into detail: the Resonate trial, the Elevate treatment-naive trial, the Sequoia trial. So these are all pivotal and representative trials in treatment-naive CLLs, elderly patients, and again, without going into details, showing that targeted treatment is superior to immunochemotherapy in CLL. And as I said, CLL is the first, let's say, model disease where actually chemotherapy is dead when you have access to targeted treatments. So let's go to the Sequoia study just as an example. What can we achieve with targeted treatment in CLL first line? So it's a trial which has three interesting arms, three interesting cohorts. And this is illustrated here. So you have treatment-naive CLL, 65 years or older or younger, patients who are unsuitable for FCR. And you have three cohorts, as I said. The first one we are focusing now is a randomized comparison between Zanu and bendamustine rituximab, non-fixed duration, classical bendamustine rituximab. And we will go to cohort 2 and 3 a little bit later. So you see the patient characteristics. So patients without del17P, keep in mind that still 50% had unmutated immunoglobulin heavy chain. So they still a higher proportion of unmutated patients in arm B, 50%, and arm C, and we will come back to this later, there were 65% with unmutated IGHV. So we stay in cohort 1, very simple message, what you can achieve. There's a major difference, significant difference towards in favor of the zanubrutinib arm when we look at PFS. And when you look at the unmutated versus mutated, you see that actually also for the unmutated patients, zanubrutinib is better than BR, which is a very active immunochemotherapy regimen, but I think a very clear difference. When you go now into different subgroups, del11, trisomy 12, complex karyotype, again, just as a take-home message, zanubrutinib is always superior to R-benda. And this is shown here with a hazard ratio showing the significant advantage of this new, let's say, treatment concept. Also here, when you look at the forest plots and all the different subgroups, a very robust data set favoring zanubrutinib in contrast to bendamustine rituximab. So it was published 2.5 years ago, very robust data set also with extended follow-up, no difference in overall survival, which shows the efficacy of salvage treatments. So toxicity, I think it's interesting because when you look at the cardiotoxicity of zanubrutinib as a class, as a compound belonging to the class of covalent BTKIs. Actually, cardiotoxicity was very low, comparable to BR. When you look at hypertension, also here, not a major difference, again, showing that second-generation BTKIs can be very feasible. So we stay CLL first line, but now with patients dealing with patients with deletion 17p. This is the arm C here, which was just presented in the summer meeting, so very fresh data. You see here zanubrutinib single agent, non-fixed duration treatment. What can we achieve with this treatment concept? Clinical characteristics, by definition, 100% had deletion 17p, 52% additional TP53 mutations, complex karyotype, around a little bit less than every third patient. So a very unfavorable patient population. And this is what you can achieve in the era of covalent BTK inhibitors. Median PFS not reached, and after 5 years, over 70% are without any progression. The same for mutated versus unmutated. So I think with the overall survival 5 years, 85%. These are very powerful data with a oral single agent treatment, which is well tolerated. And I think we don't have to go into the summary slide as illustrated here. So now we stay in CLL first line. Again, the concept of targeted treatment, but now with the idea to combine 2 targeted treatments, zanubrutinib plus venetoclax. IV, AV, we'll show this in a second. So what can we achieve with this combination? You see here, this is arm D, a little bit over 100 patients. There was a cohort with deletion 17, and there was a cohort without deletion 17p. And now you have this combination regimen. And I think it's a very interesting study because, of course, it first combines, but it has early stopping rules. So it means you don't have to take venetoclax, you don't have to take in particular zanubrutinib forever, but you can stop. And these stopping criteria are listed here. Of course, it's clinical research, it's not daily clinical life, a little bit complex. All conditions must be met, and you see you need a complete remission or CRI, and you need an undetectable MRD as defined here, and the peripheral blood and the bone marrow, and there's a minimum of cycles you have to receive venetoclax or zanubrutinib before it is allowed to stop treatment. So it's quite strict, but nevertheless a very interesting concept to move away from a non-fixed duration treatment to a personalized treatment, which allows you to modify the treatment duration according to the response of your patient. I think a great idea. Patient characteristics illustrated here. Of course, with the differences between the deletion 17p between the different cohorts. And this is what you achieve. Now, when you look at CR/CRI, it's very robust between the cohorts with deletion or without 17p deletion. So it acts quite largely independent of the 17p deletion, at least with regards to the deep responses. And when you look at the proportion of patients achieving undetectable MRD, you see again that there's no major difference. So it's largely independent again of the existence or the occurrence of a deletion 17p or not. I think these are really very interesting data. I highlighted this in blue. You need longer to achieve undetectable MRD with this combination in patients with deletion 17p. You see median 19 versus 11 months. So there's a difference, but to the end, you are able to achieve to get the same proportion of patients into undetectable MRD. And now when you look at the PFS in this combination with or without deletion 17p, and this fits quite well to the MRD data, there is no major difference. You see here, 89, 93%, it's more or less the same. So again, very encouraging data. Median follow-up is not that short. It's a little bit less than 3 years. So let's see with longer follow-up, but as I said, encouraging data. And safety profile, you know, the debate with IV. There were no major toxicity signals. You have the hematotoxicity, but for instance, when you look at cardiac toxicity, so there were no problems, let's say, with major cardiac toxicities, which is a limitation of IV. And for time reasons, we don't go through, but I think I mentioned everything. So now what about relapse refractories here? We have these ESMO guidelines, and you are aware that, you know, depending on the duration of response, depending on your previous treatment, you have the different treatment options, again, being dominated for sure by covalent BTK inhibitors, acalabrutinib, zanubrutinib, ibrutinib. Of course, venetoclax, rituximab, still very important treatment option. So I think I mentioned this trial already before. So this is now an extended follow-up of the Alpine study, which again shows, you know, the power of covalent BTK inhibitions and also the power of second generation BTK inhibitors. And this is the only data set where we have a head-to-head comparison between zanubrutinib and a second generation BTKI zanubrutinib versus ibrutinib in CLL. There's a second one in Waldenström. And what you see is also with the extended follow-up, there's a significant superiority of zanubrutinib compared to ibrutinib. And I have to go through a little bit faster, very robust data, independent of the subgroup and the forest plot favoring zanubrutinib. These is, I think, very important data. These are now the patients with the deletion 17p, and also in the subgroup, you have a robust and highly significant. It's a 50% hazard ratio. So it's a nearly 50% risk reduction to experience a progression in patients with deletion 17p when you were randomized into the zanubrutinib arm. So this is not bad. And when you look here, again, the PFS ibrutinib with or without deletion 17p, and these are in the greenish are the zanubrutinib, the bluish the ibrutinib arm. So there is a major difference. This is the CR/CRi showing numerically higher deep remissions with zanubrutinib, but I think the slides I showed you before are the most important. Again, no difference in overall survival. So there's a numerical trend favoring zanu, but no statistical significance. And why is this? I think there are many reasons, but probably again, you are able to give more zanubrutinib than ibrutinib, as illustrated here. So treatment discontinuation was much less in zanu versus ibrutinib. So what about most recent developments in CLL? I just want to mention two abstracts. The Amplify study, it was approved now, I think in May by the EMA in Europe. I don't know whether it's approved in your country. A very important study which tested AV plus obinutuzumab versus, let's say, standard FCR/BR in patients treatment naive. I think important without deletion 17p or TP53 mutations. And this just shows you the treatment regimen. So it's a fixed duration treatment, 14 cycles of Acala and venetoclax as shown here for 12 cycles, starting 2 cycles after initiation of acalabrutinib. And you know, some of you know the data when you look at the PFS. The winner is AVO, if you want so. But first, it was powered for the comparison between AV, FCR, BR. So there's a significant, highly significant difference between AV and FCR, BR, and also AVO, as seen here, is highly statistically superior to FCR. BR, when we now look at the unmutated patients, I think that's interesting. You see quite a difference between AV and AVO, so we can discuss this later on. But importantly, again, both acalabrutinib arms, as illustrated here, are superior to FCR BR. And when we look now at the mutated subgroup, so the better patients, let's say, the advantage shrinks between AV and AVO, so there's no major difference, and also there's no statistical significance towards FCR or BR. Again, here highlighted, you see a difference in the PFS according to the immunoglobulin heavy chain status. Yeah, when you look at AV, there is a difference. You have less efficacy in the unmutated. When you add obinutuzumab, this difference is gone, which might be an argument to use AVO in unmutated patients with CLL. We know that obinutuzumab is important for MRD, yeah, and this is also shown here. AVO is much more efficient than AV in inducing MRD negativity, which might be reflected in the higher efficacy in the unmutated patients with CLL. Overall survival, I think it's an important slide here on the left side because you don't get anything for nothing. AVO has a numerically inferior overall survival compared to AV. So more toxicity, and I think to censors COVID-19 death is at least debatable. I think it's not really a clean approach, so we should take the left one. So more toxicity with AVO. Importantly, no VTs here highlighted in red, but more, as I said, grade 3, 4 infections with AVO. So always think about this. Balance the slide I showed at the beginning between toxicity and efficacy. I think a very exciting new development are BTK degraders. Just as an example, it's an early phase 1/2 trial, CLL here as one entity, which was treated, heavily pretreated CLL patients. You see median 4 number of prior lines, 90% discontinued because of progressive disease, the covalent BTK inhibitor. And this is the safety profile. They are well tolerated. We know this also for Waldenström. You see here these BTK degraders, the toxicity profile, again, hematotoxicity, but think about median number of prior treatments were 4, so well tolerated. And you see here very rapid and significant response when you look at cytopenia improvement here, and this is also shown here graphically. After 8 weeks, you see this effect in platelets, and again, it's the same what we see in Waldenström. And when you focus now here on the total cohort, what can we achieve in this heavily pretreated patient population? Around 80% overall survival. And time to first response, I highlighted this myself in red. So it's very fast acting, very encouraging data, which shows you don't have to give up the principle of BTK inhibition, even when you are progressing to covalent BTK inhibitors. So I skipped this, and just a few slides on Waldenström. Because we see also in Waldenström the power of these covalent BTK inhibitors. In Waldenström, we have different genotypes depending on the mutational status of MYD88 and CXCR4. We have only MYD88 mutated patients, we have double mutated patients, and we have very few patients who are not MYD88 mutated. So we have different genotypes in Waldenström, a different situation compared to CLL, and we have implications. So for ibrutinib, we know this is the pivotal trial which led to the approval of ibrutinib in Waldenström, we know that depending on the genotype, you have a gradient of sensitivity towards ibrutinib. You see the major response, which means partial remission or better, 90, 60, 0%. So there is an intrinsic resistance towards ibrutinib in the double mutated and the MYD88 wild type patients. This is also shown in the PFS, sensitive, intermediate, and you see quite refractory patients depending on the genotype towards ibrutinib single agent, also with regard to PFS. So we have zanubrutinib, and this is another head-to-head comparison between zanubrutinib and ibrutinib. Now in Waldenström, mostly relapsed patients, but also some treatment-naive patients, and we have seen that ibrutinib is not active or to a much lesser extent in MYD88 wild-type patients. So cohort 2 treated these patients with zanubrutinib single agent, and let's see what we have as data. So first, the response. So what we see here in yellow are the deep responses, and you see zanubrutinib is inducing over time always a higher proportion of patients being in deep remission. So this is the randomized comparison in the MYD88 wild type. This is important because you see, remember, ibrutinib induces 0% major responses in MYD88 wild type. So in this observational cohort, small number of patients, but nevertheless, you see a major response of over 60% in MYD88 wild type patients. So this is a clear-cut difference towards ibrutinib. Again, here the difference with deeper responses. There was a numerical advantage favoring zanubrutinib, but no significance in the PFS, no difference in overall survival. But the major reason for us to recommend zanubrutinib is that when you have CXCR4 mutated patients, you see a higher rate of deep remissions, 10 versus 21%, when you go for zanubrutinib. Again, it's just a numerical trend, but longer PFS in CXCR4 mutated patients. And the other, even more important reasons is very simple. Again, zanubrutinib is better tolerated. This is shown here when you look at the proportion of patients with dose reduction, treatment discontinuation. It always favors zanubrutinib, and this is why it's just simply more feasible. Also, when you look at hypertension, atrial fibrillation, diarrhea, zanubrutinib is better tolerated. So we have a third approach, ibrutinib rituximab, which is important when you don't have access to zanubrutinib. So here, the idea, you have, again, mostly relapsed Waldenström, some treatment naive, and you do a randomized phase 3 trial like the ASPEN trial before, ibrutinib rituximab versus placebo rituximab. Huge difference, not actually very surprising, in favor of ibrutinib rituximab. And based on these data, ibrutinib rituximab was approved for Waldenström. So what is exciting is that also like zanubrutinib, it acts more or less largely independent of the genotype. So when you have a MYD88 wild type patients, you could also give ibrutinib rituximab, but of course zanubrutinib is more feasible. And the same also for deep remissions, largely independent. You see here 80, 70, 73%, largely independent of the genotype when you add rituximab to ibrutinib. So these are the take-home messages. So when you have a MYD88 mutated CXCR4 wild type patients, take zanubrutinib single agent. Yeah, you should not take ibrutinib rituximab. It's too complicated. It's a doublet. It's not. It's more difficult to apply. So when you have access to zanubrutinib, you should take zanubrutinib. Of course, when you don't have access to zanubrutinib, ibrutinib is still, of course, an option in MYD88 mutated CXCR4 wild type. So when you have a double mutated patients, zanu is first choice. Do not take ibrutinib. So if you have no access to zanu, then take ibrutinib plus rituximab. And in the wild type, do not take ibrutinib. take ibrutinib, rituximab, or zanubrutinib. There's no direct comparison, but of course, single agent zanubrutinib is easier to take. So I skip this. So there are just to mention just a few developments. Venetoclax, I don't know whether you have access, but it was now also presented at the last year's at the summer meetings with an extended follow-up. Venetoclax as single agent is active also in patients progressing towards prior BTK inhibition. And we recommend it quite often. It's off-label also in Germany, but normally it's accepted by the health insurances in patients where we don't have any treatment options anymore. Patients who got ARC chemo, BTK inhibitors, they progress. Venetoclax single agent is an option. There is pirtobrutinib. We have no access to pirto in Europe, unfortunately. But again, when you have such a patient, discontinuation of covalent BTKIs because of progression, think about pirtobrutinib. Perhaps you have a possibility to get your hands on pirtobrutinib. Well tolerated. Look at grade 3 or higher. It's the same in CLL. So it's a great drug. And I think these are my last slides because this BTK degraders, it's the same study I showed you for CLL, works great in Waldenström. See how fast this drug acts. And again, after 8 weeks, they already show a nadir in their IgM levels. Bispecific antibodies in Waldenström, more or less no data. CAR-Ts, more or less only case reports, but I can tell you they are currently, the bispecifics, investigated. CAR-Ts, we are still waiting for appropriate clinical trials. And with this, I'm at the end. 5 minutes over time. I'm sorry for this. It's not easy. But I think really the future looks bright, and I'm happy to discuss. And I stop my slideshow and perhaps give back to Perry, and we can discuss. And we still have case reports, but I don't want to take too much time.
Thanks very much. This was really a masterclass in CLL and Waldenström's, and there have been more than 150 participants that have
Wow.
benefited from your expertise this afternoon. So thank you very much, Prof.
And Perry, so I'm completely open to share my slides to everybody. So whenever anybody wants to have my slide set, so please just mail me.
Yeah, fortunately, the recording is available online, and it's open access. So I mean, I'll start out really perhaps with a philosophical question from my perspective. In these indolent lymphomas, what level of response do you think is clinically meaningful? And does the paradigm differ between continuous and fixed duration therapies? I mean, is MRD negativity an important objective we should be pushing our patients towards, and at what cost?
Yeah, no, I think it's a great question. I think it really depends a little bit on the first on the type of indolent B-cell lymphoma and the situation you are in. For instance, follicular lymphoma, we would never enforce a CR in first line. But what we learned when you look at the bispecific trials in follicular lymphoma or CAR T-cell trials in later relapses, when you don't achieve a CR, it's a treatment failure. The PFS of patients not receiving a CR, a metabolic CR, is a catastrophe. So you see here it depends. MRD plays a role, I think, in CLL. It's still science. It's still, it's research, but I think to tailor treatment or to individualize treatment, MRD negativity will be very important. The MRD negativity per se, I would say, is not the treatment goal, but just to use it as a tool. I give you one example. MRD negativity in unmutated CLL, it's easier to achieve than in mutated. Nevertheless, they relapse earlier. Why? Because not the MRD negativity in a static way is important, but also the dynamics. And what we have learned is, despite achieving faster MRD negativity, the dynamics are so different biologically in these unmutated CLL cases. You see, it's a very complex field, but as a tool, yes, yeah.
So perhaps to bridge to that, I mean, you showed the data of triplet combination for CLL. In your uh, in your hands, which patient would you select for CD20 BTK inhibitor venetoclax-based therapy?
Yeah, it's a good point. So I showed you the data. So for sure, not for the mutated ones, not for the TP53 deleted, makes no difference. I think there I have no hints for this. For the unmutated, I'm you could debate it, but it comes at the cost of toxicity. And the overall survival, there is no difference at all. So this is why we are very, let's say, passive in adding obinutuzumab, for instance, to AV.
Yeah, yeah. So I think on a more practical note, you know, um, you showed us the risk of cardiovascular toxicity with BTK inhibitors. I mean, in Germany, do you have a cardiologist assess all of your patients? Is this necessary? I mean, I see generic ibrutinib is on its way, so hopefully the doors will open for us to this in the future. But healthcare resources are limited, and many patients will find it difficult to perhaps have a full cardiological assessment.
I
Is this
completely agree. Yeah.
reclusive?
Yeah, so let's say, so in of course we do always a cardiac history, that's clear. We do an ECG. But in a young fit patient without any cardiac history, we don't do anything. Yeah, and only in the elderly ones where we have hints of cardiac comorbidity, we do also an echo. Um, but in the majority of patients, we don't do it. As you said, even in Germany, that resources are limited. And in particular with AV now, which I don't know whether it's available in your country, I think, of course, we perhaps need a longer follow-up and so on, but it looks really like that it's less cardiotoxic than IV.
Okay. So I mean, if there's anyone in the audience that has a comment, I mean, you're welcome to raise your hand or put in the chat box. I'm monitoring those, but yeah, it's to switch maybe to a thought about Waldenstrom's, and I mean, our time is coming to an end, and I don't want to keep you unnecessarily, but I couldn't quite understand, and perhaps you can explain why in MYD88 wild type patients we get a response to zanubrutinib. What is the mechanism of action? I mean, it's that there's less off-target tyrosine kinase inhibition. Is it an off-target effect? How does it work?
No, I think it's a great point because, in earlier times, you always thought also in acute myeloid leukemia that dirty drugs might be good for efficacy. Yeah, because who knows with all these concepts of targeted treatment. But it looks like, so of course we don't know, but we think that the difference is really the on-target effect of zanubrutinib. We know that zanubrutinib has also from when you look at pharmacodynamics has a higher on-target effect than ibrutinib, and we also know that, for instance, ibrutinib is not working in follicular lymphoma, which is also MYD88 wild type, but zanubrutinib is working. And probably it's a threshold issue, and the higher on-target efficacy makes the difference. But of course, we don't know, but we are quite confident that this explains the difference.
So I think this segues well to a question from Sharaf Narwa in the chat here, who's asking if you still find any place to use ibrutinib. where acalabrutinib and zanubrutinib are available. I mean, you showed ibrutinib rituximab in
Yeah, very
Waldenström.
simple. Yeah, very simple. So let's say everything is freely available. A patient who is on ibrutinib and is doing well, we would never change. Yeah, never change a winning team. There's no reason to switch or whatever, because you have this new second generation BTKIs when the patient is doing fine. Every new patient we put in Waldenström on zanubrutinib. Yeah. And in CLL, we put it on zanubrutinib or acalabrutinib. With the IV, it was it's a difference. Yeah, but now as AV is also approved in Germany and Europe, I think the trend moves also towards AV.
Yeah. I think there doesn't appear to be any other questions. I think I'm going to ask one closing question, really just for completeness sake. We didn't touch on it on the slides, but just in one sentence, can you describe how you incorporate BTK inhibitors in mantle cell lymphoma? Because this is, I think, another big area of use.
Yeah, one sentence. Oh, okay. So I tell you, the triangle study, first line, young patients, ibrutinib is standard now and just approved by the EMA. So in young patients, ibrutinib combined with DHAP, R-CHOP, ibrutinib rituximab maintenance is standard. In the relapse setting, ibrutinib is standard. We use pirtobrutinib now in mantle cell lymphoma as a concept of covalent BTKIs. And of course, there are data ongoing with zanubrutinib, sonrotoclax, and so on. So second generation BTKIs. So I think we are waiting for that these data are maturing. So very clear, first line relapsed, dominated by the concept of covalent BTK inhibitors.
And just lastly, the elderly mantle cell lymphoma patient, can they benefit from BTK inhibitors?
Yeah, so SHINE, BR plus BR plus ibrutinib not established, too toxic, to make it short. Now the ECHO trial doing the same with acalabrutinib. I think it's a major move. So it's approved, and I think this will make a difference because in Germany, BR or internationally, BR is very popular. And the data are very convincing that when you add now Acala, you get really very nice data, in particular and also in high-risk patients. So this is why we think that with the ECHO trial, there's a change that the concept of BTK inhibition also now moves into the elderly first line. Yeah,
Okay.
and there we could discuss longer. So there's the enriched data, not approved so far. Just perhaps one word, when you have high-risk features in mantle cell lymphoma, elderly patients, we have the feeling that a chemotherapy backbone is still important. When you look at the enriched data in the high-risk subgroup, and you look at the ECHO data, it looks like that BR as a backbone is very good in the high-risk elderly first line.
Okay, that's, I think, a very good, an excellent way to end this meeting. I'd like to thank you again, Prof.
No, you're welcome. We should have
sharing your
2 hours
expertise.
or 1 day, but
Yeah, we can go on forever, and we don't want to prey on your kindness. I'd like to thank everyone's attendance, and again to Beijing and Blood SA for establishing this session and this platform. It's up to me just to wish everyone a pleasant afternoon and evening and a great rest of the week.
thanks a lot.
Thanks very much.
Bye-bye.
Bye.